Hello, everyone. Good evening. Nice to see you. Thank you so much for joining our webinar. So tonight's session, we're going to be focusing on research looking at how effective the vaccines are in people with blood cancer. So we've got an excellent panel tonight, and I'm really grateful to be joined by them all. So I'm going to let them do their introductions. So Peter, would you like to start?
Good evening. I'm Peter Johnson. I'm a medical oncologist and I specialise in the treatment of lymphoma, and I work down in Southampton on the south coast.
My name's Emma Morris and I work in London at UCL, and I'm a bone marrow transplant consultant, and I'm also a professor of immunology.
Hi, I'm Pete Hillmen. I'm from a haematologist up in Leeds. I have an interest really in chronic lymphocytic leukemia and also in aplastic anemia and bone marrow failure generally.
Hi, I'm Gill Murphy and I'm a Blood Cancer UK ambassador, and I am a blood cancer patient. I was diagnosed with acute lymphoblastic leukemia and successfully treated with a stem cell transplant.
Great, thank you so much. So as you can see, we've got a brilliant panel, and I don't think I introduced myself. So I'm Rachel Khan and I'm the Research Communications Manager at Blood Cancer UK. So I wanted to give you a little bit of background first about what the work we've been doing and why this isn't so important. So as all of you know, the blood cancer community, 230,000 people have been shielding for over a year now, and which has been very difficult for loads of people. Gill, I'm sure you'll agree with this. It's taken a massive toll on people's physical and mental health. And the vaccine offers people hope of returning to a somewhat normal, active, economically active life. But at the moment, we don't have answers for people with blood cancer because the clinical trials of the vaccines didn't include anyone like you. And so what we quickly realized is that we need to understand how people with blood cancer respond to the vaccines. And around January, we kind of convened a group of researchers, everyone you see on this screen, who were planning work to look at vaccine effectiveness, to try and understand what was going on and to kind of fill any gaps if there were any areas that no research was taking place. And that was successful. We brought together, I think, around 20 researchers who were all planning different studies, but we quickly realized that there was no funding to do this work, or there was very, very little funding to do this work. So what we've been doing since January is we've kind of convened everyone together, and we've been trying to fund this work. And we've gone to other incredible charity partners like Myeloma UK. We've spoken to societies like the British Society of Haematology, and we've been speaking to industry. And we're really pleased to say we are now at a stage where we have an open call for research looking at vaccine effectiveness in people with blood cancer. So it's been a lot of hard work. We are at a place now where we can start funding some things and get some answers for people with blood cancer. But there are various people on this call who are doing various bits of research. So I thought I would ask them what they're planning to do first. And Emma, if I can come to you first, that'd be great.
Yeah, so I work at UCLH, which has a very big haematology centre. In fact, we all work in very big haematology centres. And we have a number of different consultants trying to understand vaccine responses. So, and by vaccine response, what we really mean to say is we're trying to understand how well patients with blood cancer who either have a diagnosis of blood cancer or who are currently receiving treatment for a blood cancer, how well their immune system can respond to the vaccine, and whether their immune responses to the vaccine are anywhere near the same, both in size and in quality, to that which has been observed in healthy volunteers who formed all of the trials that allowed the vaccines to be licensed and used in the general population. So we've got a number of groups of people at UCH who are getting together patients who are going through the vaccination process, and we're collecting blood samples before and after their vaccine to see if we can measure their antibody responses, but also importantly measure their T cell responses. So the T cells are cells that can expand in the bloodstream and actively kill normal cells in your body that are the home for the virus when the virus infects you. And the immune system relies on both these antibodies and the T cells to eradicate the virus. And so we're trying to understand that in groups of patients who have lymphoma, particularly B-cell lymphomas, and also patients who've had CAR T cells for either lymphoma or leukemia. And then a couple of my colleagues at UCH are looking in patients with myeloma and with patients with acute myeloid leukemia.
Great, thank you so much, Emma. That sounds like a really interesting piece of work, and I'm sure lots of people listening will be really interested to know the results of your work. So please keep us posted. Pete, would you like to explain what you're doing?
Yeah, thanks, Rachel. So yeah, similar to Emma, we obviously are concerned in terms of the blood cancers and blood diseases are such a wide variety of different conditions, and it may not be the same for all blood cancer patients. So I think the Blood Cancer UK vaccine task force is very important to draw everything together, as you said. And so we're doing work looking at, first of all, are patients on immune suppression for bone marrow failure, so PNH and aplastic anemia, collecting samples before and after vaccinations, both the first and the second vaccination, to look at serology, so the antibody response and T cell response. Also within the CLL patients, we have large trials on patients on treatment for CLL, either previously or currently on treatment. And I think as these types of therapies target the immune system, it wouldn't be a surprise if the response to vaccines was reduced as well. And it's how we optimize that. So we're testing patients within the trials in a study run through Birmingham. And also one of my colleagues is leading the myeloma, similar work in a myeloma arm of that study. I think the other thing to talk about is we need to get rapid answers, because all our patients have been vaccinated very close together quickly, and they need to know how they respond. But also, it's that basic knowledge which will allow us to, first of all, advise patients the best way to behave now, but also how can we optimize the responses going forward, because we need to build on the lack of knowledge in which groups of patients really need better strategies to get responses to vaccines.
Absolutely, that's really, really important. And yeah, we absolutely want to fund this research as quick as possible and get the answers as soon as possible. So that's a really good point. Peter, would you like to explain what your team are doing down in Southampton?
Thank you very much, Rachel. So as Emma and Pete have said, we know that people with blood cancers have an immune system which is not normal, and especially the treatments that we use for lymphoma are designed at affecting lymphocytes, the cells of the immune system. So it's no surprise at all that many of the treatments we use for helping people to recover from lymphoma also suppress the function of their immune system. And we've seen during the last year, unfortunately, that people with blood cancers in general and lymphomas and myelomas in particular seem to be very susceptible to coronavirus infection. And if they catch coronavirus, then a much higher proportion of people get very ill. And unfortunately, quite a few have died as a result of the infection over the last year. So we are very keen to find out as quickly as possible, number one, how effective the vaccine might be in people with lymphoma, particularly people who are just embarking on or going through or have recently finished treatment, and to know how much protection they can get from that. And of course, that's incredibly important for people planning their lives. So the huge success of the vaccine program has meant that we've had to get this research started very, very quickly. And we particularly wanted to measure immunity before people had the vaccine as well as after, so as to be able to make a really clear comparison of the two. So my colleague Sian Lim in Southampton has set up a study which is going to run in half a dozen different centres across the UK, where people with lymphoma are being treated in large numbers. And we will ask them to give us blood samples before they're vaccinated at all after 1 dose of vaccine and after 2 doses of vaccine. And some people, we won't manage to catch them before they're vaccinated because almost everybody has been now. But we've got quite a lot of people. It's about 80 people that we managed to have blood from before the vaccine program really got underway. So we'll have something to compare with. And the plan is to recruit several hundred people who've had the vaccination, and that'll allow us to look at the responses in the antibodies and in the T cells, very importantly, as Emma says, compare the different vaccines, and in some respects also compare what the different illnesses do, because we think that some types of lymphoma may have a more profound effect on the immune system than others, and we need to know if that's reflected in the way that people's bodies respond to the vaccine. And really what this is about allowing people to have some sense of how protected they're likely to be by the vaccine, and also whether, for example, if we need to revaccinate people as new variants of the coronavirus emerge as the year goes on, how effective we can expect booster vaccination strategies to be as well. So very important to get this information systematically as quickly as possible, so that we can give people advice about how well the vaccine is likely to work in their particular circumstances, and look to the future and planning of strategies, because we think the coronavirus is going to be around for some time yet.
Thank you, Peter. That's a really helpful explanation, and you've touched on a couple of really good points about the research there, that we want to know what someone's response is and how long it lasts. And once we have those answers, there will be kind of a follow-up piece of work that will say, you know, how can we boost it if it is low, or yeah, similar things. There are a couple of questions coming in. I know we touched on the 3 studies that Pete, Emma and Peter are doing, but there are a couple of studies asking for, there are a couple of questions asking about studies in other disease areas. So I just want to give you a really quick rundown of the ones that I know of, and the ones that our task force are planning by disease type. And I think we've got a pretty good spread of at least someone doing something in each disease type as it stands. So in CLL, we've got a study at the University of Birmingham that we actually promoted a couple of weeks ago that many of you might be signed up for, and they'll be looking at antibody response and T cell response. We've got Dr. Simon Stanworth, who is looking at this in people with AML. We've got Claire Harrison and Dragana Milochkovic, who are planning and looking at vaccine effectiveness in people with CML. We've got Dr. Beth Payne, and I think the SOAP study, which you might have seen results on last week, will look at something more specifically in people with MDS. We've got Claire Harrison looking at MPN. Of course, we've got Sian Lim and Emma looking at people with lymphoma, as Peter and Emma have just said. But we also have Andy Petit, who will focus specifically on vaccine effectiveness in people with follicular lymphoma. We've got 2 studies looking at people vaccine effectiveness in myeloma we're aware of. One is part of a study called Octave, and another one is called Prepare. And then we also have a study that will look at people who have received stem cell transplants or CAR T cell therapy specifically, and look at vaccine effectiveness in those people and when the most appropriate time is to vaccinate those people after transplant. And then, of course, we've got Pete's study, which is looking at people with aplastic anemia and PNH and other bone marrow failure disorders. So we do have quite a good spread. I appreciate that's a really top line description of them all, and we are putting together some more information on them all, but I want to reassure you that there are studies prepared and being planned in all disease types, and we're hoping kind of to support as many of them as possible, depending on how much funding we get.
Many people patients might be really keen to be part of these studies, and it may not be possible for all of you to be part of a study or to be recruited if it's not, for example, open in the centre that's treating you. But I'd like to reassure you that as Rachel's just described, the breadth of the studies that are being planned in the UK for patients with blood cancer means that we hope each study will have enough patients recruited to it that we will get really useful information for patients with all the main types of blood cancers and blood disorders on all the main types of treatments that we use in the UK, that we will be able to generate answers that will be relevant or applicable to you, even if you're not actually recruited to one of the studies.
People listening might be wondering why we're doing all these different studies. Why don't we just do one big one? Wouldn't that be easier? In practice, it's because we've needed to move very quickly to get the studies going. And that's sometimes easier to do at a relatively small scale. But the important point is that with the leadership from Blood Cancer UK, we're going to bring all the information together from these different studies that we're doing to make sure that the whole is bigger than the sum of the parts. So although there's lots of different things going on, these will all come together to make sure that we've got as reliable and as robust information as we possibly can. And I think that's a really important bit of leadership from Blood Cancer UK.
Absolutely. Thank you for shouting about us, Peter. That's a really important part of our work. So what we've been doing over the last couple of months is making sure that all of these studies are as aligned as possible. So when we have data, we can all feed them into one analysis and kind of compare and contrast them. And just to say that we've also been speaking to people internationally doing studies. So in the US, in Australia, in Israel, and the hope is that we'll be able to pull data from all those different studies and kind of increase our numbers and make that data and findings as significant as possible. Gill, I just want to come to you because I know you've been part of our task force since January. You've been sitting on it as our patient representative. How have you found it, and you know, how important is this work to you as someone who's had blood cancer?
As you mentioned earlier, Rachel, a lot of us have been shielding for a year, pretty much all the time. And it's been challenging, and I think almost as soon as the fantastic news about the vaccine approvals came through, there were questions about from the blood cancer community about, well, will it work for me? What vaccine can I have? Will I be able to stop shielding? Some really, really important questions that really reflect on our quality of life, but not only our quality of life, but the quality of life of those that we share our lives with. Families have been split, and families have also had to shield alongside us. So these are really, really important questions, and it was just with a huge sense of relief when I attended the first vaccine task force meeting, when I heard actually what you were planning to do and what all our amazing researchers were planning to do, and to work at speed to get those answers for us as quickly as possible, because it's really important that those of us who may still be at risk know about it. And it's also really important that those that, eventually that those that know they may not be quite as risk as others can sort of start to think about stopping shielding. But I think we might come on to the issue of shielding again at some point. So I'll hand back to you, Rachel.
That's a really good point. And Pete, I was actually going to come to you about that shielding next. We've had a couple of questions in the comments particularly about antibody tests, and is it worth people getting their own antibody tests? And I wonder if you can touch on that, Pete, but also kind of just talk a little bit about how you should interpret the results and what it means in terms of changing or not changing your behaviours.
I agree. And just one other point to make about the task force is as well as the international component, which I think is really important, is the lobbying to change policy, because our patients are not the same as every other person in the country. So we have and you have had access to the government effectively. So I think that's a really important aspect of the work. I think one of the concerns for us, and I think this is across the board, is that first of all, a test, the serology test is what, if people are going to do tests locally, it's likely to be what they're going to get results on more rapidly. And those tests can be negative, obviously, from some of the results we have, or if they're positive, patients may relax their guard and assume because they're vaccinated that they're protected. And one of the important aspects of all of the work that you've heard described is to actually understand whether patients are protected and whether they really should be stopping shielding. Of course, as shielding officially ends the end of March, it's creating a big challenge for our patients, I think. And in my opinion, certainly for many of our patients, is that they should not be dropping the guard at this point when there's still a reasonable amount of the virus around in the community, and we don't know how protected they are, even if they've had the vaccination. So I think it's very clear that the vaccinations are safe, and so anyone's got the anxiety about the safety of the vaccines, and our patients should have them, and most of them have had them. But until we get more information, or until the rates of the virus have gone much lower, we shouldn't be dropping our guard.
Do we even know which cells confer the most protection against COVID? Is it antibodies? Is it T cells? Do we know that? And actually, how much meaning can we take from antibody tests?
Yeah, so I think there's a couple of things to say there. There are sort of three components of the immune response, and there's a bit that nobody really talks about called innate immunity, which is the immune response that happens within the first 6 hours of the virus entering your body, and it happens within cells, and a whole load of genes get switched on inside the cells that make them try to reject the virus, and make them difficult, makes it difficult for the virus to pass from one cell to another. And generally speaking, innate immunity is in most of our patients with blood cancers and lymphomas and are on treatments, we would expect their innate immunity to be similar, maybe not exactly the same, but quite similar to other healthy individuals in the country. But what is different is that many people, as both the Petes have said earlier, either have abnormal B cells, which are the cells in the body that produce antibodies, because of a lymphoma, or because the treatment they've received or are receiving is designed to kill off their B cells, because some of those B cells are malignant. So many patients don't make an antibody response. And antibodies are sort of proteins that circulate in your blood, and they stick on to viruses, and they help the other cells of the immune system actually kind of eat them up and destroy the virus. So that's one part of the immune response, and that's the one that most people talk about because it's quite easy to measure antibodies in the blood. But the other really important part of the immune system is your T lymphocytes, or your T cells. And we used to call these killer cells or cytotoxic cells. And these are really smart cells in your immune system that can actually almost see inside other cells in the body, and they can see if they've got virus inside them, and they can actually kill the cells. And what we know from other viruses is actually the best immune response is one where you make antibodies and you have a group of T cells that are able to recognize an infected cell and kill it. And we are beginning to understand that patients who don't make antibodies because of the treatment they're on, or if they don't have B cells, may still actually be able to make T cell responses that can protect them and eradicate the virus. But it may take longer for that to happen. So the virus may persist in them for longer. And the only other thing I would say, which I think in response to a previous question from someone, Rachel, about the different types of antibody tests, basically, if you receive any one of the vaccines that are currently being given in the UK at the moment, they basically dupe your body into thinking it's been infected by the virus, and they deliver a bit of the COVID virus that's called the S protein or the spike protein, and it can be delivered in different ways. But that's and the antibodies you make in response to the vaccine are antibodies that are very specifically recognized and stick onto the spike protein. So they're called anti-S antibodies. But actually, the early antibody tests that were developed and used in hospitals to see whether you had actually had an infection are generated against the nuclear protein of the virus. So they're called N antibodies. So if you do choose to, and we can discuss this later, whether we think it's worth it, if you do choose to get an antibody test, if you want to see your response to the vaccine, you need to make sure you're being tested with an S antibody test and not an N antibody test, because that will tell you if you've been infected with the actual virus itself.
Please remember that antibodies aren't the only measure of how protected you are against coronavirus. There are other things that are really important. Your immune system is made up of a whole army of cells who are really incredible and intricate and are all involved in fighting the virus. So if you get an antibody test and you have antibodies, brilliant, but that's not necessarily something that tells you should change your behavior. If you get an antibody test and you don't have antibodies, don't panic, because there might be other cells that will be giving you protection. So I really want to get that message across. And there's a couple of questions in the comment about returning to work after your first jab. Is it safe? I would say to that you should discuss it with your clinician. But if you are under pressure for going back to work and don't feel comfortable doing so, please get in contact with our support services. Our number is 0808 2080 888. And we can help you with that, and we can speak to your employer and we can send them information, because all of this is really complicated, right? And the general person is not an immunologist and doesn't understand the ins and outs of that. And we were more than happy to support you speaking to your employers. So please do. We've had a couple of questions coming in about remission and how, where do people who are in remission stand? Do they count as people with blood cancer? What do we think the vaccine response will be like in them? Is it of someone who has active disease, or is it of someone who doesn't have disease?
How quickly somebody's immune system recovers back towards normal after they've completed treatment, and if they've got a blood cancer that's in remission, depends a bit on what type of blood cancer and a bit on what type of treatment. So the answer is, like almost everything we talked about this evening, it's complicated. As a general rule of thumb, people who've had something like lymphoma treated with chemotherapy, we think that their immune system is generally back towards normal by about 6 months to a year after they complete treatment. If you have something much more intensive, like a stem cell transplant, then it generally takes over a year, which is why we revaccinate people for things like childhood illnesses a year after a stem cell transplant. If you are having continuing treatment, say, so many of the people who have lymphoma treatment, for example, will carry on having what's called maintenance rituximab over a couple of years, then we think your immune system will stay suppressed during all of that time and probably for a year or so afterwards. And the basis for saying that is that we see that people who are having maintenance rituximab treatment are more prone to getting virus chest infections in the winter in normal times. So it varies a bit according to how intensive the treatment has been and how long it's gone on. And of course, it'll vary also according to what sort of blood cancer you have. So I talked about lymphoma, but I think leukemias may be a bit different, and maybe Pete should comment on that.
Yeah, I think I agree entirely. And the issues, I think, for certain of the leukemias, such as, well, certainly CLL, chronic leukemias, and myeloma, which are B-cell diseases, that the disease itself is immune suppressing, and some of the treatments we use are more immune suppressive than some of the lymphoma therapies. So certain chemotherapies, or certainly some of the targeted treatments. So I think the evidence we have is that the immune deficiency, if you like, after treatment with some of those therapies can last longer than, for example, for some of the lymphoma treatments. So my take on it would be that the further out, if it's a chemotherapy-based treatment that you've stopped, then the further out you are from treatment, the more likely you are to have a normal immune response, assuming you're in remission still. And some of our chronic diseases, you may not be in a good remission, and we have evidence that the depth of remission helps from an immune response perspective in chronic leukemias. So I think that's the first thing to say. Some of the chronic therapies we use for these diseases will suppress the immune system, and the evidence is it does. And someone mentioned before, the myeloma and certainly CLL patients on treatment are more at risk with this disease. And then finally, I would say that some of the patients who are on early watch and wait, even without treatment, are probably immune suppressed as well. So even it's not necessarily just the treatment, the disease itself can likewise cause a problem. So I don't think one size fits all is the issue.
That's a really good point, and I think we'll come back to watch and wait in a little bit. Emma, did you want to add to that?
Yeah, and I just, with my sort of transplant consultant hat on, there may be a few of you out there who've had either an autologous or an allogeneic transplant, and I think actually, as Peter and Pete have said, it's very individual at what stage after your treatment your immune system gets back to normal. And we know for some patients after bone marrow transplant, they genuinely have a completely normal immune system and they're in remission. And, you know, I've had discussions with patients advising them originally when the shielding letters went out just to everybody who'd ever had a bone marrow transplant ever, even if they were 15 or 20 years post-transplant and completely well, for example, that actually they didn't need to shield. They had a normal functioning immune system. They weren't on any medications. Whereas there are other patients who may have problems after their transplant, like graft versus host disease. They're on treatments for that, and they will be more at risk. And I think most of the autologous transplant patients who have who remain in remission, we would expect that your immune system to be pretty normal, actually. So again, I think if you are worried about that, ask the doctor looking after you or one of the team looking after you, because they'll give you a feel for how recovered your immune system is.
So I'll just give a shout out for the non-cancer patients, because there may be some patients with aplastic anemia, which is we use very immune suppressive therapies for, and some diseases where it's not as immune suppressive. For example, with PNH, we don't think it's as bad, or MDS, myelodysplastic syndrome. So I think that the point that Emma makes is we should ask your specialist or the team, because they will give you specific advice to your own situation.
Gill, please.
And I was just going to echo what Pete and Emma have said about seeking advice for your situation, because we are all very different. And as Emma has said, do apologise, I'll put my teeth back in. We have patients who are on particular treatments for graft versus host disease post-transplant. And I'm really fortunate that I'm not in that situation, but I also know that I've have a particular issue with picking up respiratory diseases, and I don't react particularly well to viral diseases. And that's sort of been my recent medical history. So with that in mind, my medical team have advised me to be pretty careful and to keep safe and keep shielding. So that's it's going to be very individual for everyone. So just really please just seek advice from your medical team, and they're the experts and they really know you as an individual.
I think that's a really important point, and you know your medical team are there for you. They know you better than anyone else. They know your diagnosis better than anyone else, and use them. Please speak to them if you have concerns. It's really, really important. So we've had a couple of other questions in about watch and wait, and whether the research studies being planned will include those on watch and wait. Peter or Emma, do you want to start with this one? Will you be capturing any data on people on watch and wait?
Yes, and I think Pete wants to say something as well, but certainly in people with lymphoma, and this is usually people with low-grade lymphomas who perhaps have very small lymph nodes and the lymphoma is not growing quickly. We are very interested to know how easy or difficult it is to get a response to a vaccine in those people. We suspect that their immune system may be a bit less effective than usual, but because they haven't had any treatment, we're optimistic that we'll see good responses. But yes, we're definitely going to ask them to take part in our trial.
Great, thank you. And Pete?
Yeah, for CLL patients, of course, watch and wait. 90% of patients are watch and wait to start with, and that's always a big area of anxiety for our patients, and they are included in the Birmingham CLL study. In fact, most of the patients I think probably are watch and wait, and so we will get that information fairly quickly for that group of patients.
That's great. Yeah. An awful lot of people with blood cancer are on watch and wait, and so it's absolutely vital we collect information from people. And I think this is kind of the different treatments everyone's on and the different stages of treatment, if on any treatment, are all the things we're going to draw out from all this research to kind of understand really what treatments do suppress the immune system to an extent where you don't get a response to a vaccine, which ones aren't so bad, and that will really help us going forward and inform decisions. We've had a couple of questions through about dosing of vaccines and the most appropriate doses to give people with blood cancer. And now I think some of this is on the off the back of the news. I think 2 weeks ago now, the concept of time is completely gone in my mind, but I think it was 2 weeks ago, the SOAP study published some results which kind of indicated that people with blood cancer might not have a particularly strong antibody response. And the study looked at cancer patients in general as well, so those with solid tumours, and sort of said, you know, it does look like the sooner you can give the second dose of vaccine, the better immune response you get. Now, we didn't have results that made it particularly statistically significant in people with blood cancer, but there are questions about whether it's better for people to have it at 3 weeks rather than 2 weeks, 12 weeks. So just before I open up to everyone to answer this, I just want to let you know that Blood Cancer UK have written to the JCVI, which is the Joint Commission for Vaccination and Immunisation, and they are the individuals who are a panel of experts who make decisions on the dosing schedule and the prioritisation of the vaccine in the UK. And we have asked them to allow clinicians and haematologists to exercise their clinical judgment. So if the clinician feels that a vaccine should be brought forward to 3 weeks, then we've asked that that should be the case. Now, we haven't had an answer yet, and we don't know what their response will be, but that is something we're asking for. Who would like to take this question?
I don't mind starting. I mean, it's we're all smiling. We knew this would be one of the hot topics for tonight, and I think the first thing to say is that obviously when those results came out, they were on, I think, the BBC website and the BBC News. They were quite widely reported in the press and in the media. I imagine that it was pretty gutting for everybody who was sitting at home with a blood disease or a blood cancer to see how poor the number or how low the percentage of people who with blood cancer who got antibody responses after the first dose of the vaccine compared to, for example, people with solid cancers, and even more so compared to healthy people without any significant other illnesses. So I think we please understand how much we appreciate how concerning and worrying that is for you, and how disappointing that must have been. I would, however, say that the study was very small. There were very small numbers of patients with a real mixed bag of different diseases and different ages. But it is likely that patients, for all the reasons we've already discussed, with blood cancers will not produce as good an antibody response as other patients with different types of cancer, just because the treatments, as we've said before, that we use are very powerful, and they're often very, very specifically designed to actually damage the immune system, because many of the cells that are the cancerous cells in patients with blood cells are actually immune cells. So, you know, we're trying to damage those cells so that we can kill the cancer cells or stop them coming back. And that a side effect of our treatment is obviously an impact on the immune system, which isn't the same for people with lung cancer or for people with bowel cancer, because those cancers don't involve their immune system. So I think what the data showed was that the antibody responses in patients who did make them with blood cancer were lower than in the other cancers. So the actual concentration of antibodies circulating in the blood was lower when it was detected. and that when they looked again at 5 weeks after the first dose of vaccine, it was lower again. So in fact, that probably they'd had a bit of a rise in antibody and then it had petered out quite quickly, which has made us keen to try and petition for patients to get their second dose of vaccine in sooner to help boost that antibody response, so that it keeps going up rather than sort of goes up and then peters out again. And I think there are other patients receiving treatments that impact on their immune system. There's lots of patients with joint disease and rheumatological things who have very powerful immune suppressing drugs. So you're not alone. And there are many doctors and organizations like Blood Cancer really petitioning on your behalf that we can be allowed to give the second dose of vaccine sooner. But I still want to reassure you or remind you that, again, this is just looking at the antibody responses, and this was in a small group of patients, and we haven't yet got detailed information about the T-cell responses that may well be protective. And actually, we don't know whether any of those patients who didn't make a good antibody response actually went on to get COVID and were infected. So there are lots of unknowns in the situation. I think we would all like to be in a position, and the caveat here, this is my personal view, we would like to be in the position to offer our patients a second dose sooner. And I think we would all like to be in the position to be able to offer people who live in their households vaccinations sooner than maybe otherwise indicated on the basis of your partner's or your family's medical condition. And we are campaigning for that. But as you know, there is there are 60 million people in this country, and basically we will all be set. The more people get vaccinated, gradually the safer we will all become. And that's true for all of you who may not make very good vaccine responses. The more actually Joe Bloggs in the street gets vaccinated, the more of them that are vaccinated, the safer you'll be.
That's great. And Pete, feel free to add.
Just to follow up with Emma, I mean, to reiterate, the study was small, but I guess the findings were not unsurprising because of what we said before. There was some data on T cells, and the T cell responses in that paper were great. Where a higher proportion of people responded than the antibody responses. So that's slightly more encouraging, I guess. It was only with the Pfizer vaccine, so we don't have data on others. Although I'm sure there's a question that people are asking, and I get asked a lot: which vaccine should I have? Well, we have no evidence that I'm aware of that compares the vaccines and tells us which one, even in a normal immune system, is better. And I don't think we have any evidence in our patients either. But we do need more data on the AstraZeneca vaccine, which most of our patients have actually had when we surveyed our patients. And then the data on the second vaccine, there's only 5 patients, I think, in that study that had with blood cancer that had a second vaccine. 3 of them did respond, and that was often later. So I agree with Emma. We feel that it would be optimal to have an earlier second vaccine if possible, according to the whichever vaccine you have, the schedule that you should have it on. And we have been writing to our patients' GPs to ask them to do that, and some have been able to access it. But I think that's why lobbying the JCVI and the government to allow us to do that more systematically is important. And finally, and I would agree entirely with Emma, the vaccination of people living in your household and people you come into contact with regularly is obviously a sensible thing to do to protect yourself from infection. I think there was a study which showed that there's a 30% reduction in infection if your partner's been vaccinated or your people you live with. So that's a sensible thing to encourage your friends and certainly household contacts to do.
When we're thinking about coming out of shielding, that it is, if you want to meet with people outside, I think actually that's pretty safe. It is quite hard to get infected outside unless you're stuck in a rugby stand at Murrayfield or something, which I guess no one's going to be, or in a football stadium. But if you're sitting in your garden with friends having a barbecue, or you're going for a walk, sitting on a park bench, meeting up with friends, I think, if you do want to mix with people and people that you're close to haven't been vaccinated, do it outside. And I think, actually that's reasonably safe. And I think, there are potential benefits for your quality of life and your well-being and your psychological well-being that are really, really valuable.
Please still get your vaccines. So the SOAP data, which came out saying that the antibody response might not be good in people with blood cancer, that was on 50 people with blood cancer. To give you an example, there's 477 people currently watching on Facebook. You all probably have different diagnoses. You're probably on different treatment. You're probably on at completely different stages. And you probably will have different vaccine responses. And that's what we're trying to find out from this research. The study a couple of weeks ago was incredibly small. It took data from, for example, one person with lymphoma, one person with leukemia, and try to compare them. And you can't really compare apples to pears. And whilst it's good initial data, it doesn't give us kind of really strong answers. So please still go and get your vaccines. It's really important because, we just don't know yet. We just don't know how well people with blood cancer are protected, but we are trying to find out. And everyone in this call is, I'm sure, supportive of that.
And we also don't really know yet. I think it's fair to say, and that Peter do disagree with me, but that we don't really know what the actual numbers mean. So how big the number, how big the concentration of antibody needs to be, because actually the proof of the pudding, whether the vaccine has worked, is not what the level of antibody you get in your blood. It's actually the fact that you don't get infected with COVID, or if you do, you get a runny nose and it goes away, or a dry cough, but you don't get a chest infection and you don't end up in hospital and you don't die of it. So, stopping you getting ill and stopping you getting an infection is actually kind of the what we're trying to achieve with the vaccine. It's not, the measuring the antibody response is what us doctors and scientists do, because we think it's a marker of how effective the immune system is, but the real marker is whether you get infections or not.
I think that's a really important point. There's a kind of magic to numbers, isn't there? And certainly people who've been through treatment for blood cancer will know you spend a lot of time thinking about how many platelets you have or how many white blood cells you have, and we kind of fixate on numbers. But it's absolutely true that we don't know whether this level of antibodies is makes you safer, or this number of T cells. And I think what we can be absolutely certain of is if you don't have the vaccine, it certainly can't work. And we know that particularly younger people are still a bit reluctant and a bit wary of having the vaccine. And I realize that people like me with grey hair sitting here saying, get vaccinated, I've had my vaccine, I think it's great, is not very influential, but it is so important for everybody to get vaccinated. It won't work if you don't have it. There's a reasonable chance it'll work if you do. And the more people have it, the safer we all are. And having lots of people around you who are immune is a very good bit of security, even if your own immune system isn't great. Having lots of people around you whose immune system is not stopping the virus being carried is terribly important.
We know from other vaccines that it may be that our patients need more than 2 doses even, or we have to try a different type of vaccine going forward. And it may be that the first 2 vaccines give you the base, get you to the base camp to get a better immune response later on. They're the sort of studies we're going to have to do when we have the information, and that you having had the vaccine will I'm sure help when we move forward to try and improve the response you may need to have.
It's kind of probably of no surprise to anyone that I would definitely support an earlier vaccination schedule for blood cancer patients. But although I do think the JCVI have done an incredible job, and certainly should be applauded. And the vaccine rollout has been stupendous. I think it's just been incredible. But it is fine. You know, I think they've took a gamble to increase the dose to 12 weeks for the Pfizer vaccine, and for the general population, I think that was a very good choice. But potentially for blood cancer patients, it's not the best decision. And certainly vaccinating our household members would be appreciated as soon as possible. But I think, you know, coming back to Peter and Pete's comments about just getting the vaccine at all, even though I know that it's not necessarily going to give you the same level of protection as other people, I don't know that for sure. But I feel that, coming back to Emma's comment, it's kind of like going to be that tipping point that maybe keeps me out of hospital. Maybe keeps me, if I get into hospital, maybe keeps me from going into a intensive care unit. So I think whatever protection we get is a bonus. So it's just really important that blood cancer patients get their vaccine, and it's vitally important that we have a chat with anyone we know that is a bit reluctant, and have a really good chat about getting them vaccinated as well.
Absolutely. That's a really good point, Gill. And, you know, we've talked about for a long time blood cancer patients having some protection, and this kind of notion of some protection is really confusing, but it does essentially mean, you know, it might be that if you do come into contact with COVID, instead of being in hospital, you have mild disease and you're in bed for a couple of days. So, you know, it's really important to get the vaccine to kind of try and benefit from any protection you might get. And just to kind of close this bit of the conversation up a little bit, I just want to reiterate that we are speaking to the JCVI both about letting clinicians exercise their clinical judgment on the dosaging, and we will keep you updated on that. And we are also talking to them about vaccinating household members. So please, if you're not already in contact with Blood Cancer UK, please kind of follow us on our social medias and sign up for our e-newsletter. And if anything changes, we will of course let you know as we get the news. We're all looking at how effective they are in how effective vaccines are in people with blood cancer, and we hope they will be effective, at least for some people, if not all. But if not, what's being planned, and what might people with blood cancer be able to benefit from in the future to protect them against COVID? Pete, do you want to start with this?
Yeah, I think first of all, a lot of the treatments of COVID have definitely improved in terms of how we manage patients and prevent them going on to ICU and getting more ill. And I think many of those will benefit our blood cancer patients community as well as other patients. So that's the first thing to say. The studies looking at passive antibodies, so the ones that might prevent infection if someone's been exposed, or even prevent it long term. That basically means giving rather than you making your own antibody against the virus, giving an engineered one that may stay around for a while and protect you in that way. So it's not active, it's passive. And so those studies are ongoing as well at the moment. So I think there are a number of things that are happening. And we talked also about the reduction in the community. So the more people vaccinated, the less the virus is around, less we're going to be exposed to it. I think they're important things. And then we're going to be looking at how we can improve vaccine response. I think they're going to be the really important studies going forward, because I'm an optimist and hopefully we will be through this soon. But we have to be prepared for it not disappearing quickly, or for another virus in 5 years' time. So we need to understand how we can improve responses to vaccines for our patients. And so I think we are getting there.
If I could just go round the group and ask everybody what your one take-home message for people at home would be.
Get your vaccine, but make sure you look after yourself. Stick with the guidance from the government about not meeting up with people until it's safe. Look after yourselves, and if you have any doubts at all, speak to the team looking after you, or give a call to the Blood Cancer UK helpline.
I would reiterate absolutely everything Peter said, but I would also say don't sweat the numbers. If you do get blood tests back about antibody levels, really, because that's what we're trying to do on your behalf. We're trying to work out what they really mean. So keep safe, get vaccinated. and be hopeful.
I think we are almost through this pandemic, and certainly with the vaccinations we're getting there. So we should be optimistic for all our patients as well as ourselves. So and we're almost there. So we need to make sure that we don't relax too early. So what I've been advising my patients is, if we're with this roadmap to getting out of the pandemic and waiting for 4 weeks, maybe our patients should be 4 weeks behind everyone else, and seeing what happens to the pandemic with a change in schools or whatever the relaxation is before they take the next step. So you don't want to get caught in the middle of an increase in the virus. You want to make sure it's okay. And I also concur with the social distancing outside is a sensible way forward as the weather warms up a bit.
Get your vaccine and proceed with caution. Don't rush off out as soon as the pubs open. Just really, really be careful. Talk to your clinicians about the risk, and just be aware that there's still a risk out there, but there is light at the end of the tunnel.
Everyone you see on the screen, so Peter, Emma, Pete, they're all planning studies looking at research effectiveness in people with blood cancer in various different ways, as we heard at the beginning. If you are in a position to donate to Blood Cancer UK, that would be really, really appreciated. Every little really does help in this instance. I'd also like to have a big shout out to Myeloma UK and the British Society of Haematology, who have been absolutely outstanding in supporting all of this work with the vaccine task force and getting all of this research underway. We couldn't have done it without any of you, so thank you so much. And then lastly, I would say that what we have discussed this evening is a difficult topic, and you've all been shielding for over a year now, and we understand how difficult it is, and we don't underestimate that at all. And if you do need support or someone to chat to, a friendly voice on the end of the phone, that we are here for you, and our support line number is 0808 2080 888. Take care.
Thank you.